Good morning, good afternoon to everyone around and who is listening to this webinar. My name is Professor Bettina Borisch. I am the Executive Director of the World Federation of Public Health Associations and a Professor of Public Health. I'm happy to welcome you all. Before we start, I would like to let you know that we are waiting for your questions, and please prepare them, put them in the chat and be ready. We'll try to have as many of your questions answered. But before, I'm really glad to chair this session about precision medicine, and you have all heard the word, is almost a buzzword. And the development of precision medicine is driven by the technical possibilities of next generation sequencing, artificial intelligence, and the likes. And so, like all new technology, raises a number of ethical questions. But you may say, in a world where one size fits no one, everyone deserves personalized care. Personalized medicine has enormous potential, from prevention through diagnosis to treatment, and many professionals and patients expect high benefits and have positive attitudes towards it. However, patients and professionals also perceive some risks. Should hopes for precision medicine benefits be fulfilled, then the ethical principle of justice would require an unlimited access to precision medicine for all people. Turning personalized medicine into an opportunity for citizens and patients requires the commitment and international collaboration of all stakeholders to define common approaches, common regulations, standards, and so forth. The European Union and China are leaders in the field of personalized medicine. So the integrating China into the International Consortium for Personalized Medicine, IC2PRMED project was born and funded by a grant from Horizon 2020. So during this webinar, international experts will discuss the best approaches to facilitate international collaboration and sharing best practice. And it's my real pleasure to have as an introduction to the topic a call on Professor Stefania Boccia. She is a full professor of hygiene and preventive medicine at the Università Cattolica del Sacro Cuore a Roma. And she is a real specialist in personalized medicine, is also active at WFPHA as being the president of the epidemiology section. She is really the one who is also the spirit behind the project and helping us to go forward. So lovely to have you, Stefania. Could you give us an introduction into the IC2PRMED project and where we stand with it? Over to you, Stefania.
Thank you very much, Professor Borisch. Thanks, Bettina, for the introduction, for the very nice words on me. And good morning, all the people that are attending the seminar and the colleagues that are online and that will be talking later on. So I actually have 15 minutes to present the main results of the Integrating China into Personalized Medicine project with the main achievements we had so far. And I will give you also some flavor about the roadmap that we are still not, we already elaborated, but is not available yet, publicly available. So I will give just a flavor of the main content of the roadmap at the end of my speech. So I will start with an introduction about what is personalized medicine about. As you might know, and already anticipated by Professor Borisch, it is an approach that refers to a model using a characterization of individual phenotypes and genotypes, aiming to tailor the right therapeutic strategy for the right person at the right time, but also to determine the predisposition to disease and to deliver targeted prevention. In this context, I cannot avoid mentioning what is ICPermed. ICPermed stands for International Consortium for Personalized Medicine. That is an European-funded project in 2016, still running, that aims to provide a platform to support communication and exchange on personalized medicine research, funding and implementation, thanks to the high participation of public and private not-for-profit health research funding and policy organizations from Europe and beyond. ICPermed Consortium published a couple of years ago a vision of personalized medicine in 2030 that builds upon 4 main pillars of data technology, intersectorial synergies, health system reforms, and education and literacy of citizens and health professionals. So why IC2PerMed? IC2PerMed is a CSA, which stands for a Coordination and Support Action Project, funded by the European Commission in support of the International Consortium of Personalized Medicine, and it is composed of 10 partners. I have a slide in a second. And the overall goal of IC2PerMed initiatives is to enable the convergence of European and Chinese stakeholders towards a common approach in personalized medicine. So basically the overall objective of the project, if I have to state this in a very few sentences, is to provide key solutions for enabling the convergence towards a common approach in personalized medicine research, innovation, development and implementation between European and Chinese stakeholders, from policymakers to healthcare beneficiaries, but also to seek to insert such developments into a broader international context. The vision of IC2PerMed project is to become an efficient lever to support European-Chinese collaboration for the development and implementation of personalized medicine and enabling population also to access personalized, smart and inclusive healthcare solutions by 2030. The project will last 4 years, and it has been kicked off 2.5 years ago in Rome, just at the very beginning of the pandemic. And it is organized in 6 work packages, and it is participated, as I told you before, by a number of partners, both from European and the Chinese side. You can read in this slide. And also, the project is not supported only from European funding research structure, but also from the MOST, which is the most relevant funding agency in China that has a ministerial endorsement. So we were very, very glad to receive such endorsement from the government in China almost 1 year after the project has been kicked off, as a recognition of the very relevant topic also from the Chinese counterpart. So the roadmap. Today, I want to tell you at the end of this presentation the main elements of the roadmap, but I have really, I think it's very important for me and for the audience to realize how we did reach the content of the roadmap, which is one of the main output of the project by itself. Because the roadmap synthesized the main topics and priorities that has been discussed during the Work Package 1 and Work Package 2 activities that has been summarized in terms of actions. So how did we reach the roadmap? We did reach the roadmap thanks to a number of activities that has been realized using a stepwise approach. So starting from Work Package 1, that basically took the first year, the entire first year of activities of this project, where we mapped all the personalized medicine policies and programs, both in Europe and in China. Afterward, we moved to an expertising activity related to the Work Package number 2, where, building on the mapping exercise, we did include a number of European and Chinese experts that volunteered to discuss the main elements that emerged from the mapping exercise in order to find common priorities and common challenges in Europe and China concerning personalized medicine. So this is just to summarize what we did in the first 2 years and to tell you where we are here. So we are here at the month 30 of the project, and we expect in the coming year and a half to also create a more solid approach with delegation visits in China, hopefully, and also from Chinese partners in Europe to step also and to start new research projects in personalized medicine. So when we started the mapping exercise, work package 1 activities, we realized that definition of personalized medicine were not exactly the same in Europe and in China. The personalized medicine definition in Europe, I already told you at the very beginning of this project, in China, the definition was similar to some extent, but there was a specific reference to the importance of an approach that also endorsed the traditional Chinese medicine. However, also in China, it was very relevant when it comes to personalized medicine to talk about efficient, safe, and sustainable approach to prevention and treatment that should be tailored to individual patients based on the genetic makeup, but also on lifestyles and the general cultural context. The main steps of personalized medicine in Europe is reported in this slide, and it is very long, so I cannot spend that much time about this, but just to tell you that in 2006, more or less, the Public Health Genomic European Network started. We had afterward the Personalized Medicine Initiative funded by the DG Research. Then we had the Council conclusion in 2015, and the IC-PERMED vision published a few years ago when the IC-PERMED was launched. When it comes to the mapping exercise, we did realize that in Europe there are a number of initiatives funded also at the country level. I can mention those in UK, so 100,000 Genome Initiative, also the Genome UK, the Estonian Genome Project that aims to sequence 15% of the Estonian genomes, but also the FinGen that in Finland aims to sequence 7% of the Finnish genomes. And in 2018, 22 European countries plus UK and Norway signed the Member State Declaration, the 1+ Million Genome Declaration, on stepping up efforts to create a European data infrastructure for genomic data and to implement common national rules enabling federated genomic access. When it comes to China, instead, we see in this roadmap what is Healthy China. So Healthy China 2030 came out after a number of steps as a program that covers 2016-2030, and it is currently still underway, and it is divided in 29 chapters that include the public health, but also environmental management, food and medication safety. This program has been approved by the Political Bureau and aims to have a Healthy China over the next 15 years to promote a new engine for economic and social development, improving structural reform of medical supply and fulfill China commitment to international community. The Healthy China is one of the goals of the 13th five-year plan that runs from 2016 to 2020, which is made by 20 goals itself, and discussion of genomics is presented in this 13th five-year plan. And the plan intends to prioritize research and develop diagnostic and treatment equipment, including genomics, as well as in vitro diagnostic equipment. And the plan advocates for accelerating the deployment of genomics and other biotechnologies in China. In China now we have also the 14 five-year plan that focus more on Healthy China 2030 as target, but is not mentioning genomics specifically. So we still stick to the 13 5 years, basically. When reading the programs of Europe and China in personalized medicine, we did identify the mapping stage a number of common objectives like upscaling health system to reduce ineffectiveness, overcoming fractionation in the domestic market, the need of standardized data and access to the data protection issues, the patient-citizen engagement and public understanding and trust of personalized medicine, and also the healthcare workforce literacy and training. All these mapping exercises has been summarized in a number of deliverables that accessible so that everybody can read in more detail was what I was discussing very briefly now. Thanks to the mapping exercise, we were able to create 3 working groups across 3 different topics and to have a number of experts that volunteered to discuss these topics from European and Chinese perspective in order to identify a number of priorities. The priorities have been then summarized into action in the roadmap. So priorities have been identified thanks to a number of working group workshops that they've been organized the last year. After the workshop, all the experts have been challenged in Delphi surveys, and at the end of the day, each working group identified different priorities. I cannot read all the priorities, it will take too much time, but just to tell you that the priorities are different across different working groups and across different topics of each working groups. In Rome, we met a few months ago to validate the results of all this discussion and all these priorities that in fact are just 56, and summarize the 56 priorities into 7 main topics and related action that are presented now in the roadmap. As I told you before, the roadmap is not available yet for the public. This is why I can just give you some information, just nutshell information today. So I can anticipate what is being presented very much in detail in the roadmap that will be released publicly at the end of the year. So the working group number 1, which is about shaping sustainable healthcare, focus on awareness and empowerment of citizen and patient, education and curricula of healthcare professionals and healthcare sustainability in general. Because for personalized medicine to be routinely implemented in clinical and public health practice, both patients and health professionals should be aware of the possibilities offered and how to make the most of them. These priorities has been identified both from European and Chinese counterpart. So just to tell you a few examples, because we don't have time to go into too much detail, when it comes to improving, we reported that given the need for informed, empowered and engaged and responsible citizen, there is a need to deepen digital literacy, knowledge of health data, public trust in institutions, and easily accessible, reliable and understandable sources of medical information. Public trust should be fostered and strengthened in order to protect patient rights through clear data governance in accordance with the Helsinki Declaration and the GDPR, implementing technical solutions to safeguard cybersecurity, citizen and health practitioner engagement, and also developing comprehensive consent procedures where needed. When it comes to promoting, improving healthcare professional literacy and expertise, valuing integrity and ethics could help foster personalized medicine. So we recommend to foster collaboration between professionals from different specialties and between professionals and stakeholders, while establishing more partnership among countries to also facilitate sharing of best practice. When it comes to fostering, a system for continuous assessment of technologies and process already in use and a change of perspective in HTA is needed to integrate end user perception into the whole innovation process. Working group 2 activities focused on big data and ICT solutions and on bringing innovation to the market. When it comes to bridging, with regards to diagnostic, promoting research in personalized medicine, aimed at more appropriate use of diagnostic tool in order to avoid overuse, overdiagnosis, and overtreatment. When it comes to adopting, social and cultural difference between European and China should also be considered when it comes to public trust in government and state authorities, trying to reach a common understanding of shared challenges within personalized medicine. Working group 3 activities focuses on translating basic clinical research and beyond, and on research funding. So fostering. Funding agency, in our vision, should tailor investments to the need of the patients. There is a need to promote the voice of patients and caregivers at all stages of personalized medicine research, from co-designing research priorities to advisory roles and enhancing educational initiatives to improve the scientific literacy of patients and researchers. Lastly, when it comes to translating, standardizing approach, including controlled access models for data sharing and clinical trials, may facilitate their implementation in patient stratification. So in conclusion, now more than ever, we are witnessing how health challenges must be tackled globally in a concerted manner, and alignment of research efforts lead to a more efficient research, reduction of redundancies. Work in the direction taken by the IC2 per med approach shall pave the way towards the realization of personalized medicine full potential, prevent it from becoming a burden for health system, and rather prove that it provides an essential and irreplaceable contribution to their effectiveness, efficiency, and sustainability. So I thank you very much for your attention, and I want to thank all the group at the Catholic University, especially Chiara Cadetto, the project manager, and Flavia Breccia. They contributed more than others, but still all the colleagues in this group to the results that I presented very briefly today. Sorry for being a bit late.
Thank you so much, Stefania. Thank you really for setting the scene. And I think we heard a lot already about China, and it's my possibility to directly turn to our first panelist, Professor Hui. Professor Hui is, first of all, a cardiologist, so a real doctor. And second, he is at one of the most important, I think, hospitals in China, National Fuwai Hospital. And I think he is one, we know him as one, who really understands how personalized, and we have heard about the differences, a precision medicine, as it is called in China, developed. So Professor Hui, first of all, thank you so much for being with us. And my first question to you, which is in fact two, is you heard what Stefania talked about China. Is it like this? Why are there differences? What are the differences? And where can we learn from each other? Thank you. Over to you, Professor Hui. Most welcome.
Thank you very much, and for everyone. And I think it's for you it's good morning. For me it's good afternoon. So the afternoon in Beijing, and I'm glad to attend this meeting, and also thanks for including me, because I work in the I'm a physician scientist, and I work in the hospital. Also, I have a very big laboratory. Totally 83 people work with me, and we did. I practiced the precision medicine for a long time, because I think for the China, for me, I think it's very good thing is if we do collaboration. In Chinese has very big population. And even rare disease, and we can get very big number. So it's very easy to reach, sometimes to very fast to reach our goal. At present, like in my hospital, mostly we practice precision medicine. It's in the two parts. First is the monogenetic disease, like in cardiovascular field, there are 309 monogenetic disease. 80% of them have been identified the disease causing gene. So we could make a good diagnosis with precision diagnosis. Also, according to this diagnosis, we can give the molecular or gene-directed clinical management, like the sudden cardiac death. So each year we have I think 600,000 people who are dead suddenly. So those are kind of people, especially the age under 35, they are the cause of them for the young people, especially under 35 years old. There are the gene mutation caused. Those gene mutation, we lot of people we use echocardiogram or ECG or X-ray, chest X-ray, or even MRI. We cannot find anything wrong with them. So we, if we use this gene diagnosis, you can find some people, because the sudden cardiac death sometimes is the first only clinical presentation. If we diagnosis with the precision medicine, with the gene sequence, so we could find the person who are at risk of sudden death by implanting ICD, so to can prevent the sudden cardiac death. This kind of practice in the precision medicine in our country, especially in our field, most of the tracked people is the sudden cardiac death, and also some monogenetic cardiovascular disease. Because this, I think this work is very visible. So the public can see you prove they're healthy. The government see you did good things for the people. So in this way, we can track the financial mass financial support for the. So if we did something, people think this is doesn't do anything with my health. So I don't think they're gonna support you for the. So for the European, I think just now I heard from the very not very brief is I think it's a very comprehensive plan for the European China program. Very good. I also I think it's we at the beginning we should focus something people really needed, and also identify something in the cardiovascular disease or in the cancer field. Something where we can have the technique, have the method to resolve the problem, and can give some people's hope. So, and also we send this scientific achievement to the people who need it. So this is can attract more support, and also I think another thing is that in China I just mentioned big population, very big. Even in rare disease, you can very easy to get quite large number of the patients. So but this collaboration, I think I don't know the detail, because we can work together to by the big population to identify something, some disease gene or some main signal transduction pathway for in the disease in some physiological way. So in this way, I think it can improve the scientific development if we could clone some new identify some new gene. Like in the next month, our group we publish in circulation a new gene, probably the 32 new hypertension related gene, because hypertension tell us circulation tell us the paper gonna appear next 1st of November. So this collaboration, I guess also I think is very needed. The collaboration is right now. I'm sorry. Some telephone.
Oh.
It doesn't matter. I will continue. And also, I would like to mention another thing. For our prevention medicine, mostly we based on the progress of the genomic development, like sequence or to improve the sequence, less the cost. So and also I think for the GWAS results, most results from Caucasian, not from the Chinese people is very less represented in this program. That most study, so I guess there's some trans-ethnic difference, because between the we can give a lot of example from the European people, from the Chinese people. So we need, I think, those kind of trans-ethnic to solve the trans-ethnic difference in the prevention medicine field. And this is also, but I guess from your data, we can see a lot of government effort. But in my practice, in my experience, because there's 3.87 million physicians in China, practicing physician, but only less than 5% physician. I mean, 200,000, less than 200 they know something about the precision medicine, and they will practice in their clinical practice. But most of the physicians, they don't know, and they have no intention to learn it. So we need to set some example. The precision medicine could resolve them their clinical difficult problem to improve the patient's health, and so they can track the physician and the people to join this precision medicine team. And also, I think this is also very important for this program. I think European could help us to teach to educate this the clinician to understand and to practice the precision medicine. This is also very important. For one thing is trans-ethnic difference we need to answer. Second is the education, and also what I think the big population in the Chinese, even rural disease, that we can have very big population, easy to fast to get the goal to for the rural disease, because the rural disease we study, we could to improve our common disease like the PCSK9 is a French family with hypercholesteremia, but finally they found this disease in this family related to the PCSK9. Then to start to develop a lot of new generation the cholesterol drugs. So it's very good, I think. Okay, right. I will stop here. If some question I would like to ask.
Thank you. Thank you so much, Professor Hui. We really felt the passionate cardiologist who's speaking, and also thank you for putting up the possibilities of collaboration and education and getting knowledge to our colleagues around the world. You also mentioned, and that's interesting, and that makes me turn to Professor Ricciardi. You mentioned that the government in China is now really behind and putting money into it. So we see that all what we do in medicine is also quite political, and we need the support of policymakers. So I turn to Professor Walter Ricciardi, who is a professor again at the same university as Professor WFPHA, Università Cattolica del Sacro Cuore a Roma, and he is our immediate past president of the World Federation of Public Health Associations. But here I'm turning to him because he is also, has been and is again an advisor for the Italian government, the Italian Health Ministry, and is also a fine connoisseur of European health politics. That's why my question to you, first of all, welcome, Walter. Thank you for being with us. And my question to you, do you think that the political surrounding in Europe, we heard from Professor Hui, there is support in China, is in favor of, or where does the policies in Europe stand if it comes to personalized medicine?
You know, Europe is made by crisis and by the reaction to crisis. So what happened with the pandemic is that certainly there was a major crisis that made European member states understanding that alone it's difficult to face such a challenge. So this crisis has not been, unfortunately, enough to change totally the attitude, but certainly has contributed to make a change. And what's happening now is that certainly Europe, the European Union, European Commission has much wider activity in the field of health. I just want to mention two major initiatives. One are the missions, and the missions are related to major challenges that face the world. And in one of them, I'm the coordinator of the Mission Board for Cancer, but also the EU4Health, which is a major plan that aims to promote and coordinate activities to reply to all the threats that we have in the health sector. So certainly a lot has changed, but not yet enough. I just had a meeting with the scientific advisor to the most important European governments, and there is a kind of reluctance by scientific advisors to be maybe tougher in advising their government and tougher to take important decisions. I just want to mention the fact that, for instance, in Europe, we have the GDPR, which is very much protecting the privacy of European citizens. And this, of course, is an asset. It's very important to do that. But many interpretations at the local level, at national level, actually make impossible literally to do the things that we are able to do with the technology we have nowadays. And of course, we have to find a balance. I know that China has a different attitude to privacy, and with the pandemic, they have made all the data from citizens somehow owned by the government, so that the government can create a national plan and can really transfer the use of technology. India has done the same, starting from a pilot which happened in the past 2 years. Now all the data, all the health data of the Indian citizens are essentially available to government for taking important measures. And this is transforming the Indian health, because with a population of more than 1 billion people, they in the previous part of the pandemic weren't able to reach all of them. Now they are. And they can provide important solutions to populations, even in rural areas or in some deprived areas. So, of course, we have to find a European approach to this, which balance essentially privacy, cybersecurity, protections, but also the possibility of using and enforcing all the discoveries that have been made by important scientists in this field. Personalized medicine is an important part of it. There are a lot of funds. There are a lot. I'm also in the mission that I chair. We have allocated a lot of resources to invest in this. But of course, this is very important. I just want to close on the importance of collaboration between Europe and China. It's very important that we work together in order to share the different approaches to understand what are the situations that can be winning for both, and particularly for our citizens, because if we are not providing a common response to the global challenges, this is going to be a problem. So the challenges are global, the solutions are certainly local, but without a global approach, the local solution can be very difficult to enforce.
Thank you, Walter. Thank you for getting to the complex system of the EU, but also the regulations already in place, like European Health Data Space, like GDPR, a lot of regulations, a lot of things in place, as you said, concerning privacy, concerning the doubts that people may have. And I think this gets me directly to the next panelists, and I would like to welcome Dennis Horgan. Dennis Horgan, welcome. Dennis Horgan is the CEO of the European Association for Personalized Medicine. So let's say he is the civil society part of personalized medicine in Europe. So no one better than him to talk about if this is really possible in the multiple legal frames and projects that the EU has already, some of them mentioned by Walter right away. So Dennis, what is your take on the question that I would like to ask you? Is personalized medicine feasible in the European Union?
I mean, it's a difficult question. Of course, I mean, personalized medicine is presented in many of the major congresses, medical congresses. But the question is the implementation of this. So we have a lot of personalized medicine in existence in terms of diagnostics or therapeutics, but the question is bringing this into healthcare systems. And if we link this to what Professor Ricciardi said, I mean, healthcare is global, but then the question is implementation is local. The same with public health as a concept. Public health is broadly, how can population-based healthcare be delivered to different types of citizens? When I'm looking at personalized medicine, then you need to stratify different populations. And the question is, how do we do that? So you have a lot of different legislative frameworks and policy frameworks to support this. It was mentioned around the General Data Protection Regulation, which was a common EU framework to share data, but it was broader than healthcare, so it included different types of other data sets. But then often the implementation, when it came to implementation at a country level, so the EU was made up of 27 member states. So when it came to implementation at a country level, often there was a public health reason given for why the different implementation took place. So this is a key question. Often the public health community or the healthcare professionals or researchers, the implementation was different. And the same issue when we come to, say, another legislative framework was a cross-border healthcare directive, whether a patient could get access to a treatment when it was not available in their country in another member state of the European Union. And now the reason why the cross-border healthcare directive came about was that healthcare was taken out of the services directive, which was an important issue because at the European Union, you have free movement of persons, but also free movement of services. But healthcare was taken out of this, and this led to a new legislative framework called Cross-Border Healthcare Directive. But unfortunately, the implementation of this has struggled too, because a lot of the issues in terms of getting access to different healthcare was implementation at a country level. So this disrupted in terms of getting access to healthcare. So laws in itself, I think, what Professor Ricciardi mentioned as well, is a lot of healthcare is revised because of a crisis. How are we going to deliver healthcare? And the same comes when we look at the medical device regulation and the in vitro diagnostics regulation. This was revised because of a scandal in France called the PIP scandal, which was the use industrial silicone for breast implants. But of course, that was illegal to do in the first place, but it's triggered the revision of the legislation. And our question is, I mean, how does policy take place and laws take place in terms of the impact? And the impact in terms of in vitro diagnostics regulation has impacted the labs at a country level in terms of using lab developed tests. So this is the key question. The main problem when we look at public health or healthcare at a European level, often healthcare is a sovereignty issue at a country level. Even when we come with the biggest success, I would say at a public health level in terms of smoking cessation, this was not done through public health, but this was actually done through employment legislation. So in the sense that we had to protect the employees at the workplace, ensure that they have a good working place, so that the European could work at this because we're protecting employees, but it wasn't a public health issue. It is a public health issue to have a good environment to work in and stop smoking, but this wasn't the reason. So, and it needs to be more of a focus at the European level in terms of coordination and how this can be done in a more effective manner. And now there's different legislative frameworks. The General Data Protection Regulation was one example, or the Clinical Trials Regulation was one example. But now there's a recognition that there needs to be more alignment between different member states, which leads to the European Health Data Governance space. And this derives from another activity called the 1 Million Genome Project. So this is why the IC Permit 2, for example, in linking Europe to China in terms of sharing best practices, learning how to tackle the implementation gap, learning how we can tackle this implementation gap is of key concern for the broader health community at the European region as well as China. So laws have a huge impact, but I think it's more to focus on what is the policy framework to support implementation. So then you can have common best practices that can be implemented rather than there's a tendency of legislation to, restrict or limit liability. So the question is, how do we have a framework that allows flexibility and allows innovation to get into healthcare systems at a quicker and faster pace, which Europe is moving towards quickly. Thank you.
Thank you so much, Dennis. I think that when we look at our populations, both in China and in Europe, it's the people who count most, and all we do is serving people. And let me turn to Anand Jani. Welcome, Anand. Anand is from the University of Oxford, a Martin Oxford Fellow. He works a lot on social prescription and social determinants. So he is very close to populations. And I have already seen some questions in the chat that may be also, I will fear back to you. But first of all, most welcome, Anand, that you're here with us. And I would like to hear your vision on what I said at the beginning. We have to question all the things we do in terms of what is good for the people and what we need for the people. And do we integrate the most important social determinants of health into this personalized medicine move? Welcome, Anand. Thank you for being with us.
Thanks, Bettina. So I was looking at some of the questions, and
yeah,
I guess maybe one framing perspective that I can use is cash. Namely, who's going to pay for this? So if you have a universal healthcare system, obviously there's a finite budget, and we see the budgets are extremely stretched at the moment. And there's a question as to how much, I think Lucy and Rehab were also asking about.
Yes, Lucy had the question, perhaps I repeat it for everyone. What is the economics of personalized medicine? Who is paying for that? Yeah. And yes, I see then later on Stefania will go, but first perhaps Anand, you get along with your position onto personalized medicine, and then directly Stefania.
Yeah, I mean, I suppose we'll just need to figure out where the money comes from. If we have a universal healthcare system, obviously we have a finite budget. So paying for precision medicine, genomics, precision medicine from the perspective of just looking at genomics would require that we have to disinvest from something that we're already paying for, or we have to make the pie bigger. So we have to get more money into healthcare systems. And with budgets already stretched, the question is, where would that money actually come from? And here I would maybe touch on the last point, the last bullet point from Stefania's presentation for the Chinese definition of personalized medicine, which actually looks at lifestyles as well. And so if we look at precision medicine from that perspective, and if we look at the huge burden of disease that comes from NCDs, which can be prevented or brought into remission through lifestyle changes, diet, exercise. Professor Hui was talking about hypertension. So can we reduce salt intake in some way for diets for citizens in China to try to prevent diseases from occurring in the first place, or for people who already have a condition to bring it into remission? That would be, I guess, my two key things. One is who's going to pay, because we have to have these discussions. And then the second would be to sort of broaden the scope of precision medicine to not only narrowly focus on genomics and look at some of the other lifestyle related precision things that we can try to help people with, whether that be for diet, physical activity, physical infrastructure. I think Italy had a great initiative during the COVID-19 pandemic where citizens were given subsidies to buy bikes so they could support active transport. All of these sorts of things I think can also be looked at from a precision medicine perspective and personalized medicine.
If someone of the panel wants to react directly to the question that is also now in the chat by two different people, who are we going to realize that in terms of economics? And I see, if I got it right, Dennis raised his hand. Is that right, Dennis? Then
yes.
It would be up to you. Yeah.
I mean, who's going to pay for it? It's really around the question is, how do we allocate resources in society? I mean, it's not to say that, I mean, the question is, how do we allocate existing resources? Because a lot of what personalized medicine is around early diagnosis. How do we identify patients earlier to treat them earlier? Now, at the moment, a lot of expenditure is spent on the last 6 months of a person's life, the majority of the expenditure. So the question is, how could these resources be best allocated at an earlier stage? And a lot of this is around the use of advanced molecular diagnostics and what systems need to be put in place. So there's been a big discussion, for example, whether at the European level, whether we should have lung cancer screening. And this has been a question on lung cancer screening and prostate cancer screening. Now, on breast cancer, cervical and colorectal cancer, it was done from the recommendations in 2003, and the evidence is there. Now, although the studies were done at the European level in terms of the Nelson study, they're still up in the air whether we should do lung cancer screening or prostate cancer screening. And that's really a question from a public policy maker's perspective and a public health community to say how we should allocate resources. Because should resources be put into smoking cessation, or should we just put into treating lung cancer patients? So the question is, how do we allocate existing resources? And then the question is, what is the evidence needed to decide whether we should reimburse certain types of diagnostics, which has been a big issue for Europe, or therapies? So the question is really around allocation of resources, I would say. Thank you.
Yeah. I think, thank you very much, Dennis. Where do we put our money? That's the thing. I would like to perhaps turn to Professor Hui. How do you think about who's going to pay in China? I saw you have really great, interesting projects, but if it comes to the whole population, who's going to pay? The economics.
Thank you very much. This is, I think, is very different from China, between China and European, because in our country, if the people had deadly disease, very risky, and most family, they don't depend on the insurance or the public health fund. No, they will pay themselves for the family to pay. Like now, lot of expensive cancer treatment, like a CAR-T, those kind of treatment, and the molecular directed therapy for the cancer. And this is they don't they want to get the insurance paid, but usually they don't pay it. But they will family, they will pay it because the economically we have a very good shape in recent year. Now in China there has 0.6 billion middle class people, so they have some money in the pocket, and they gonna. So this is very different because this is Chinese people attitude for the you know, most expensive, and also if the people have that, they don't rely on the insurance or the government. They will take care of themselves.
Health as an individual issue and out-of-pocket paying. So that's how it works in China. I see already 3 of the panelists who want to react. And I say, ladies first. Stefania, I saw your hand up, raised first. You go.
Thank you, Bettina. I was the second, actually. Professor Ricciardi was first, but I can...
Yeah, but ladies, you know, I said ladies first.
I agree with you. Okay, so I just want to follow up what Dennis said. So the fact that we spend a lot of money in healthcare on the last 6 months of life, but in general, we learned from a number of data presented at different settings that in general, the disability time is such a long period. On average, 18 years of life are spent with at least one disability, and this consumes a lot of resources. So I think that personalized medicine can, we don't know this yet, but can definitely help in contributing to make also prevention be more effective. Because I'm personally coordinating a CSA about personalized prevention, okay? So this is just in my heart. But the fact that people do not engage physical activity as they should, or they do not stop smoking as they should, or they do not stop drinking as they should. I mean, although we have a lot of evidence about how to implement effective policy, how to implement effective communication, how to give money from the state to buy bicycle or whatever, it doesn't work. I'm sorry, in many instances it doesn't work. So why we should not think about novel way, innovative way to integrate information from genomic, from biomarker, to make people being more aware of their, let's say, health evolution since when they're adult, in order to engage them more in prevention. So thinking about also primary prevention, but also secondary prevention makes screening more effective, because people can be better stratified thanks to the new technology. So I think we cannot neglect the fact that technologies here, it can be very much cost effective. We definitely need more evidence to accumulate, but we should not disregard the fact that currently the way in which we do primary prevention is not that much effective. So I want to answer the question from the panelists about the polygenic risk score. Polygenic risk score can have the potential to stratify healthy population into subgroups that have additional genetic risk or reduced risk of certain chronic disease over the lifetime. It doesn't mean that this information can be effectively used to make more effective prevention, but why not? I mean, we should take a look at the research advancements. There are a lot of trials ongoing, and I feel a bit optimistic about that. So, you know, just to follow up what Dennis said about the importance of investing in prevention, in innovative prevention, and yeah, the fact that we should keep an eye on the research advancement. The cancer screening program will change in the coming years. We know this. And in the report of the European Commission, we read a lot about the trials that try to stratify women for breast cancer before sending women to mammography. Probably some women do not need to have any mammography before 60, or some others need to have well before, based on the genetic backup. So we just, you know, research is not really a sprint, it's a marathon, okay? As many people say, we have to keep a strict eye on the research advancement, because very much likely this would be the next future also in prevention.
Thank you very much, Stefania. And I see your passion for the risk-adapted screening and the prevention with and using precision tools. I see now, I think between the two gentlemen, I think it was Walter who raised his hand first. So, Anand, you will be next. Walter, your turn.
Yeah, and I just want to underline the importance of public health in this decision making. If public health doesn't play a role, these kind of innovation are going to increase inequalities. You know, either in the system like beverage one, where if public health doesn't prevail at decision making level, providing evidence, but also managing the decision making process, but also in the insurance system. So we have to be aware of the fact that unless we provide decision makers important support and important leadership for that, inequalities are going to rise, because of course there will be people that are going to be able to pay or I'll be able to be reimbursed, and other people that are not going to access this kind of innovation. So we as a public health people should be aware and active. You know?
Thank you, Walter. Thank you for putting the equity aspect on the scene. And now to Anand. Anand, finally your turn.
Yeah, I was going to touch on the equity aspect as well, and just touching on, I'm an American, and touching on the equity aspect and paying out of pocket. In the US, 60% of all bankruptcies, 60% of all bankruptcies are due to inability to meet healthcare costs. Now, oftentimes you will have patients who are going and can't actually make decisions about what they should or should not purchase. And so there's also an issue of actually not just informing clinicians and physicians, but also citizens, so that they're not necessarily purchasing things that they don't need to. Because with this sort of technology, you're still working in a fee-for-service model, where the more you do, the more you sell, the more you get paid. So you have these perverse incentives to actually continue doing more diagnostics, etc. Some will be helpful, some will be harmful, some will be completely useless. And I think there has to be some safeguards in place to ensure that citizens and individuals are actually protected from not purchasing things that they don't need, particularly if there's out-of-pocket expenditures. That's one thing. The second is touching on Dennis's point and Stefania's point, looking at allocation of resources. So if we look in the UK, In the NIHR, the National Institutes for Health Research, they published their annual report, and one of the headlines was most money ever spent on a type 2 diabetes prevention study in the past, I think, 20 years or 25 years. And in the report, in the annual report, they didn't actually list the amount, but then when you do a bit of digging, you can find that it was about 2.6 million pounds for a 5-year study. And then contrast that to the 100,000 Genomes Project, which was 300 million. So when you're looking at, you know, some of the strategies that quote unquote aren't working, I don't think we're actually investing enough into actually understanding how we can do some of these interventions and processes that can help citizens to stay healthy. So we actually reduce the demand side. We don't need some of these genomics and diagnostics in the first place. We don't need these medications in the first place if we can try to keep people healthy. There's also the broader issue, and this is probably not within precision, but it is a policy issue around structural determinants and whether people actually have access and a choice to keep themselves healthy. So again, touching on the Chinese definition, which looked at lifestyle, can we actually integrate some of this stuff more formally? Not, you know, I'm not saying that we don't do genomics, but I am saying that there's probably a lot of low-hanging fruit that we're not capitalizing on the lifestyle side of things. Particularly when we're looking at NCD burden. For Europe, at least, it's about 70 to 80% of healthcare expenditure. So that's about 700 billion euros per annum we're spending on completely preventable conditions. And yeah, okay, let's get the genomics, but you know, for these preventable conditions, the two key things are physical activity and diet. So can we start looking at some of the other things that we can do to support citizens to actually modify these modifiable risk factors in a precision way? So some people like Italian food, some people like Polish food, whatever it might be. Some people like German food, but within those realms, what are the healthy options for them? How can they get physically active? Some people like hiking, some people like cycling, some people like aerobics, whatever it might be. But how can we support citizens to do this? I don't think we're doing enough in that domain. And we're already jumping to these expensive diagnostics and needing, you know, all sorts of money poured into this. So I don't know. I personally don't think we've done enough on the public health side of things.
Thank you, Anand. I'm most probably with you, because as a public health person, I always think we have not done what we can do yet. And I think there is a question from the chat that goes quite into this. How can we, the question comes from Jesper Ruus. He says, I think it's how it's pronounced, what do you think is required for preventive medicine to become a better commercial possibility? And I think his second question should be linked, how to pass the conundrum of who will pay for a result that is not easily visible. So the invisibility of the results of long-term public health, how could that become a better commercial possibility? Who wants to take this question? I see Anand.
I think Dennis and raised first, but
Dennis was first. So this time Dennis first, Anand second.
I mean, yeah, on the question, what do you think is required for preventive medicine to become a better commercial possibility? I mean, I think equality was raised as a key issue in terms of at a European level, in terms of access to personalized access to healthcare. But at the same time, having equal access to healthcare doesn't equate to having equal access to the same type of care. So the question is, how do you tailor different types of treatments accordingly to different types of individuals? And that's a key question around preventative healthcare. Because if we truly go on the way of stratifying different patient populations, then the question is, how do we attract investment into supporting, for example, in the area of cancer, where I work a lot on, supporting cancer centers in having better advanced molecular diagnostics to identify patients earlier, so then you can improve their you can keep them healthier for longer. And this in a way is for preventive healthcare. And this will drive forward the innovation in the area, because a lot of the investment is focused on therapeutics around treating patients, but in fact, it should be more focused on advanced molecular diagnostics. So in this way, it will be more preventative in that sense of applying innovation into healthcare systems. And that's an issue around the commercial aspect, is because a lot of diagnostics are not reimbursed. And this is a key issue in terms of commercial viability to attract investment, and then you have developed an ecosystem around this.
Thank you very much, Dennis. Thank you for putting the diagnostic and personalized medicine high up on the agenda. I think that, yes, in personalized medicine, diagnostics is so key that we really have to always also underline diagnostics, because they go hand in hand. But I have Anand, who was almost in the same time raising his hand. So Anand, I'm curious to know what your take is on how we get the preventive more attractable for commercial. Aha, showing up his mobile phone. So now I see
Digital.
And
let's go digital. And then I don't have a smartwatch, but the smartwatch is wearables. So digital personalized prevention, where you're actually allowing and empowering the citizen to track their own lifestyle behaviors. I think that could be an extremely important commercial prospect. There's over 350,000 healthcare apps on the marketplace currently. Only a few dozen of them have actually gone through randomized control trials, but in Germany, for example, the new DIGA law, where they're actually supporting primary care physicians to utilize apps as a medical intervention. In the NHS in England, what we're trying to do is to see how we could use the NHS app, which was used for tracking COVID-19 vaccinations, and that's the means by which we can get our COVID-19 vaccine certificates. Can we create that as an interface where wearables and sensors can write information into there that the GPs can see, and then that written information the patients can also use to track their activity levels, their other vitals, etc. There's Apple Health, Google owns Fitbit now, Amazon, purchased a digital health company. So in terms of the commercials, if we're able to really integrate some of the wearables, sensors, IoT, digital health, I think that could really help to catapult prevention in a precision way, right? Because this is my phone, this is my stuff, and I think this is maybe an underexplored area that I think could be ripe for innovation, as well as something that consumers can take the powers in their hands.
so for you, this would be a commercial, exploitable area, and then also integrating into healthcare systems in the same time. Like, yeah, or did I got you right?
Yeah. I mean, so this is a means by which it can be commercially exploited, but it doesn't have to be commercially exploited in this way. So you can also create open source technology to do this as well. It doesn't necessarily have to be, an individual having to pay, et cetera, et cetera. So I think it could kind of span both, because there are free and open source apps that you can use to track your vitals. Apple Health, for example, once you buy your iPhone, you don't have to purchase Apple Health as an add-on. And once you purchase your Apple Watch, for example, you don't need to buy the extra software. Vitality Health, which is an insurance company, actually provides Apple Watches for its policyholders that are trying to lose weight and improve their health. So are these mechanisms that we can use to actually encourage primary and secondary prevention?
Yeah, there are also examples from, again, Germany, where the app for mental health, for example, is now reimbursed by the German insurance companies. So Self-AP is an app that helps mental health to be improved and to have access. And I think, yes, the digital versions is probably something that is being exploited. I would look to Professor Hui and ask, how do you see prevention being integrated into precision and the real life of Chinese people, especially as you are as a cardiologist in a place where prevention is key. Yeah.
I think yes, prevention is the key for the cardiovascular disease and for the cancer, because the cancer if we did good prevention, 60 to 70% of cancer can be avoided, because like smoking, 30%, bad lifestyle, 20%, and worse infection, 5 to 10%. This is already CCAR already told people many times. And also for the cardiovascular disease, I think Western gave us a very example, because since the 70s, and now after 40 or 50 years, we mainly take to educate people to take the good lifestyle. I thought the cardiovascular death rate decreased nearly 50%. The death rate 50% contributed by the lifestyle change, and not the 50% by the treatment. So I think prevention, the precision prevention, and also precision the medicine, this is a two-part. The prevention medicine prevention, we have a lot of to do. Is people don't take it very seriously, because I think it's for the company or for the commercial to invest this. They don't like it, because many years you can see the results. So the people also, if you go to the hospital, they want the doctor to prescribe the drugs. If you don't prescribe drugs, it doesn't tell them how to do good lifestyle. They will not very satisfied. So the prevention, I think, is very important, most important, and but it's hard to do. The commercial, I think is even more difficult to this. And for me, I practice precision medicine. Just use this precision prevention is also very important. But right now, I just want to use this technology to treat, to resolve some clinical problem. We can. It's a very difficult problem, and right now we don't have enough method to resolve it. So we take this new technology, new knowledge to solve those kind of things, especially deadly disease. And before we don't have many treatment, but now we have some treatment to save the people's life.
So thank you very much. And there's exactly a question in the chat to you, Professor Hui, to this. It comes from Martine Corral. She says, expensive diagnostics is now presented as an alternative to one-size-fits-all lifestyle change. Are there examples of low-hanging fruit at the interface? Cardiology gene variants, question mark. Question to Professor Hui. Do you have a low-hanging fruit to present?
I think it's right now we in the lifestyle food we improved a lot, and we for med field in hypertension we told people to take the DASH food and DASH style food, and a lot of vegetable and a lot of less meat. And this I think is also less dead, because in China we have ordinary people every day take 16 gram sodium. It's very high. So the government make a decision, policy to for the restaurant. They said that you sell your food maximum per day is 10 grams. Even it's a long way to the 2.4 gram American Heart Association recommended the sodium lifestyle I don't have a special for our hypertension or cardiovascular disease people. We always tell them exercise, change your lifestyle, stop smoking, and right now, several years ago, we tell people drink less, drink little alcohol. Now we told them stop, don't drink any alcohol.
Yeah, thank you. Thank you very much into the beauty of our public health work. And I would like to turn to all of you with a last question. We are approaching the end, and I will make my tour de table the other way around. So I will start with Anand, because I also know that he has to leave at 11:30 sharp. My last question to all of you would be, the IC2 permit project is not yet finished, as Stefania has shown. What would you like us in the project to do and to focus on really now? And so my question would be this one to all of you, and I start with Anand.
Well, it would be the same two things, is actually exploring the resource allocation issues. Where's the money going to come from? And then number two is to broaden the perspective of precision medicine to also include the lifestyle as well. Those would be two things that I think could be quite powerful.
Thank you, Anand. Thank you, clearly. Thank you a lot. Now I try to go the other way around, and I think if I come from backwards, it is Dennis. Dennis, with your broad knowledge about all that happens in EU, also with your former knowledge of cancer care, and as you said, you again back into cancer, where we always have the case studies first. What do you think is, if we go and finalize our IC2 permit, what should be our focus? Is there something we missed out? Should we be stronger on? Please come up very broadly, openly, with your thoughts.
I think it's very strong already, I should say. It's great work. But one key area, I mean, because it was mentioned by Anand and by other colleagues around apps and the role of apps, applications or your phone. I mean, the key question would be, would be helpful, I guess, if there was some synergies or alignment, the role of value of diagnostic information. And what are the key principles that could be shared principles between China and Europe around how do we utilize diagnostic information for evidence to make an intervention, whether on a preventative or early diagnosis or a treatment or a patient monitoring. And this issue around value of diagnostic information is a key issue in terms of driving forward innovation in the personalized precision medicine area. So that will be an area that could be emphasized in all the many areas that you have already, which is great work, I should say.
Thank you for the positive note that you gave. Stefania is smiling. I turn to Walter, because what would be your focus? Where do you see something that needs really to be underlined? Let's call it like this, because the project is really broad, but also with the given evolution and the political setting we are in now, what would you like to see as underlined?
I think that when you have such a big project, the importance is the mechanics of implementation, so it's very important now, the roadmap, validation, and then of course, the mechanics of implementation to create a situation in which all stakeholders could win. And of course, this is challenging, but it's possible because the group is great, the people that are working are fantastic. So I really rely on the fact that they can go from this preliminary part to the implementation part quite smoothly.
Thank you very much, Walter. Implementation. And now, well, Professor Hui, you have the difficult task of thinking of both China and Europe by saying what would you like for both places to be in the focus of the project? So you really have a difficult question.
I think this project, I don't know the how long it's gonna did. I think we should if it's better for me. I think it's better to focus on some disease like something like or cancer field or cardiovascular. This is very important for the public health. This kind of disease, to focus on those diseases and to identify some question. Some question can be resolved by the precision medicine. So they can like some results already give us in the European. I already know, and we will confirm it in the Chinese population, or some rare disease to confirm in the big population, patient population in China. This takes advantage. They have a big population. This is to just focus several. So you know, precision medicine already can resolve the problem to identify those kind of problem. Then we do collaboration. In this way, we could very in the right short time to show the government, show the public we did good things to them, and also they can saw the results and to attract more support. And second, I think we need also need to collect very big population, very big population, and also including the environmental factors. And this is also important. Environmental factors like US Topo told us the so-called high definition medicine. So we need those kind of big population environmental data, and also the genetic data, all the mobile monitor data together, to very big population, different population together, use the IA to make a very good to resolve some unresolved problem. This is for the researcher part. For the practice part, just now I mentioned to choose several very important questions. We focus on that question. For the researcher, and we combine the IA and also mathematician and data scientists, the epidemiology all together, work together, clinician all work together to I like to this kind of collaboration. So you need different people, different place, and but very big data we could pull together.
Thank you very much. Thank you very much also for bringing in the environmental factors. Can you hear me right? Yeah. The environmental factors.
Yeah,
we haven't talked about yet, but you're right. We can do good research on environmental factors if we pool all our big and especially, I mean, Chinese and European population. That's some point that had been not yet mentioned, but thank you very much for putting this up. Do you think, Professor Hui, we have something, because we are a majority of almost Europeans here, I count Anand a little bit as a half European, that we could learn from China and Asia in general that has been missed until yet? Because it's interesting that you call it not personalized, but precision medicine due to traditions in your medicine. Is there something we have not yet learned, or we should?
From traditional medicine?
Yeah, yes,
because,
from you,
from
China in general.
Because I'm labeled as a Western physician, Western medicine physician, so I don't know much about the Chinese traditional medicine. But I think this is for Chinese traditional medicine, the good for some chronic disease, also prevention also, they can act on the different pathway of those. I don't think this is. I don't think there are many very good study on the traditional medicine, but they're effective and efficiency. But I don't think they have very good use modern technology to study this traditional medicine. This is also good point if we start this program.
Yeah. Okay, thank you. So now it is very difficult. I come to Stefania. She is, as I said at the starting, she is the spirit of the program. And it's difficult for you when I ask you, Stefania, what would you like now that we are in the run-up to end the program? Where is on your wish list, high on your agenda? What would you like to have? If Christmas, if for Christmas you get your wish list, you know.
Yeah, thank you, Bettina. So I have to say that at the very
I think
can you hear me? Okay, no, I have to say that at the very beginning of the project, and the World Federation is a partner of this project, so you can confirm that at the very beginning of the project, we realized that we had many barriers with Chinese colleagues, communication barriers, different political system, ethnic difference, and so on. But along the path, with the collaboration of the great partners, because we had Lily Wang from BGI, Wenya Wang from Tsinghua University, and other colleagues and experts, we realized that the challenges in personal medicine are just the same. So I think that now we reach this roadmap. Today we discussed about the main challenges of medicine and the medical revolution that wants to be less reactive and more proactive by taking also advantages of the new technologies. So we should now be brave enough to implement the roadmap, start making a bilateral agreement with Chinese counterpart, and also working a lot on health professional education, because we need the new generation of health professionals that understands risk, understands genomics, understand the relevance of lifestyle and genomics together, how to communicate this to citizens and patients. So still 1 year and a half ahead of us to work together to strive towards implementation of these challenges.
may I say something?
Yeah, yes, Professor Hui, yes, please.
For the financial support for this project, I think we need make a very good plan, and I think it's can persuade the government, at least in the Chinese government, support. I don't think they lack of money. They just want to have a good project. So for the research money, I don't think they lack this kind of resources. They just want to see a good project.
So this is a real positive note. And on this positive note, I would also say, in the name of the World Federation of Public Health Associations, that we are really glad to be part of this journey, and that we continue to be part of the journey, where we see that we still have things to do. But I would like to thank here to all the participants, panelists, speakers. You were speakers, panelists, contributors. Thank you for being here with us. Thank you for Stefania telling us that we opened up Chinese-European collaboration. I think this is an important part, and that we got to know each other better and see that we have worldwide the same questions. So thank you to all of you. I wish you in the Northern Hemisphere of Europe a good day. In China, good afternoon, good evening to you, Professor Hui, and thank you to you all. I hope you take some things back with you. Also to the audience, thank you for being with us. And if there are still questions, don't worry, come back to us at the World Federation of Public Health Associations.